and Sickle Cell Day on 19 June. This month, we thought at NHA it was a good thought from our senior official that we now need to talk about breakthrough in blood advancing practices for patients with hemoglobinopathies and other transfusions. As per WHO, in low-income countries, up to 50% of blood transfusion are given to children under 5 years of the age. And there comes thalassemia and sickle cell as well. Where in high-income countries, the most frequently transfused patient group is over 60 years of age, accounting to 76 of all transfusion. Based on sample survey, it was 1,000 people there was a survey. Blood donation rate is 31.5 donation in high-income countries, 16.4 donation in the upper middle and 6.6 donation in lower middle income countries and 5.0 donation is low income countries. Now, if we see, it's only 56 out of 177 countries, 56 only reproduce this data. And if we talk about plasma-derived products, only 91 countries reported for the same. Here in Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, where we also covered blood transfusion related procedures and in health benefit packages, especially the HBP includes whole blood transfusion and the blood component including the platelet transfer, which are essential for managing the conditions like thalassemia, SCD, leukemia, and other blood related disease. If we required blood disorders, individuals with hemophilia, thalassemia, sickle, and other disorders rely on regular blood transfusions to manage their conditions and maintain a quality of life. Patients with acquired disorders such as cancer or trauma may also need blood transfusion to support their treatment and recovery. It also improves the quality of life. The safe blood transfusion help manages symptoms, reduce complication, and improve quality of life for patients with blood disorders. Now, if we talk about impact on others, the maternal mortality and child mortality is one of the cases. Now, safe blood is essential for managing maternal complication and support to the newborn. For surgery cases, if we see blood transfusion are critical for patients who have experienced severe trauma or surgical procedures. Saving lives in both routine and emergency situation, blood transfusion contributes to saving millions of lives each year. And timely accessibility of safe blood is crucial for optimal patient outcomes and minimizes the risk of unnecessary deaths or suffering. But there are consequences of unsafe blood also. Unsafe blood can lead to the transmission of infections such as HIV, hepatitis B and C, and other viruses as well. And if we talk about adverse transfusion reaction, so unsafe practices can cause allergic, febrile, or hemorrhagic reactions, which can be life-threatening. Unnecessary transfusion and unsafe practices can reduce the unavailability of blood products for patients. So it is also important that we have to understand the availability and its utilization. And inadequate blood supplies can undermine the effectiveness of health services, including emergency care and treatment of chronic condition. With these, we all understand that thalassemia children who are born regularly, it's around 10 to 12,000 children are born. With sickle cell, we have a good sickle cell mission where we are finding there is so much of disease. And not every sickler is requiring blood transfusion, but they also require it. And regarding the blood, it is very important, being a critical component, it is important that blood has to be taken up in such a manner, it's a lifeline of any health services. Now the time is that we also come and talk about these important aspects where it is going to help the country and our people who are staying at the remote areas. So today we have Dr. Dulika Seth, who is a professor from AIMS, and she's a hematologist, our mentor also. She's here with us as a moderator. Dr. I.S. Chantanya, who is from AIMS Mangalagiri, he's a HOD over transfusion medicine over there. Dr. Gopal Patidar, who is an additional professor in Department of Transfusion Medicine, and Dr. Vijay Kumawat, who is an additional professor and head Department of Transfusion Medicine in IMANS, Bangalore. So we have a very good panel today, and I'm thankful to all the panelists and our moderator, Dr. Tulika Seth, who is a mentor also, I should say like that. So to take up the panel discussion in upward. Ma'am, now it is over to you. Thank you so much.
Thank you. So, as Dr. Vinita just said, we have an eminent panel from all over the country, and we're just going to have a discussion. There are no slides or PPTs, and I would the attendees to please type in their questions if they have after we have the questions that we are going to be discussing in the panel. After that, we will have time for a Q&A, and any doubts or questions that you have, please feel free to ask because you will not get such eminent panelists to talk to later on. So first of all, I will start with Dr. I.S. Chaitanya. He is HOD Transfusion Medicine at AIIMS Mangalgiri in Andhra Pradesh. So thank you so much for joining us, Dr. Chaitanya.
Thank you.
Um, we know that blood donation is very important in all life-threatening situations, in hematology, in most departments. Blood donation is absolutely paramount. Without that, we would not be able to function. Now, what is the amount of blood that is collected in India annually? Can you give us some statistics, please?
Yes, ma'am. Actually, some of these data are not available in public domain, but I have done. So there are estimates that say just 2 years before our requirement was somewhere around 14.6 million units of blood. And 2 years before we collected somewhere around 13.6 million units of blood. So during the last 2 years also, we might have collected much higher amount than the 14.6 million requirement. But this requirement is actually biased, we should say. Because every year it is changing. It depends on the type blood transfusions are happening, the requirement changes. Similarly, from state to state also it changes.
So thank you. That's very important information. So roughly about 14 million units is collected, and sometimes it's not enough that we need. So which is the kind of blood donation that is considered the safest? And in a population, are there any calculations to decide how much blood should be collected per population?
Yes, ma'am. First of all, if I have to say which is the safest blood, I would definitely go for autologous blood. But not everyone can get autologous blood. Not everyone can blood collection before their planned procedures. And in these situations, actually, I would say trying to get a voluntary, regular, repeat blood donors' blood is a little bit safer. Then again, sometimes actually we have to see the patient's requirement also. Sometimes patient might be having some specific antibodies which may be present, which may be against general population. So in those special circumstances, maybe there may be requirement for directed donation from kith or family members also. And in some situations, like a dengue patient, I would definitely go for apheresis product. So it is not always a single component which is best for all patients. So it should be patient-centric. And if I have to discuss regarding the requirement, especially the annual requirement of maybe a country or a state, WHO states, like in previous introductory talk, Madam was telling, maybe in South Africa, the requirement may be just 0.6% of the population that they have to donate every year. Once, if they can donate, it is okay. But India is somewhere between developing and going towards developed country. So the estimates, the requirement estimate only, I think NBTC keeps those rates. But at least in the state of AP, I can say we have crossed our estimates. Our collection is somewhere between 1.3 to 1.5% of population every year. And as we are moving towards development, maybe it may cross even 3%, may even go up to 4% also. If the current trend goes on also, every person in their lifetime may require maybe taking somewhere between 2 to 4 units in their lifetime. So this is just a rough estimate, this 1% or 2%. our requirement is definitely increasing. That I can definitely say.
So thank you. You've highlighted several important things. You've talked about autologous blood collection for elective procedures. So that is something that can definitely be thought about, that would reduce the need for other voluntary donations. And you've also highlighted the component therapy. Can you expand a little bit on what is component therapy for some people who may have some questions? In fact, when I was coming for this talk, I was talking to one of my radiology colleagues, and they were talking about, how much whole blood is collected. And I said,
AIMS Mangalagiri is a 100% component center, ma'am. So the requirement for whole blood as of now, there is no actual absolute indication. Even in developed countries also, what they are choosing is except in case of emergency, when they can get O positive or O negative low titer antibody, no one is using whole blood, because whole blood doesn't have many components of blood actually. Like for example, platelets, though they may be present, it will not be functional. The labile clotting factors will be gone. So technically, whole blood contains only red cells, maybe WBC, then stable clotting factors and albumin. So this is a bigger challenge because it doesn't have what the patient may require. For example, maybe a dengue patient, he may not get platelets with whole blood transfusion. That is why we try to separate all the blood and blood, different whole human blood, which we collect into different components like packed red cells, platelets, fresh frozen plasma. We separate this way because we want all these things to be effective after transfusion also. Each and every component has a effective temperature, a shelf life separately. That is why we try to save these things separately. Like packed red cells can be stored at 2 to 6 degrees, with SAGM maybe for up to 42 days, platelets at 20 to 24 degrees in an agitator for 5 days, and FFP can be stored for up to 1 year. We separate even cryoprecipitate, cryopool plasma from fresh frozen plasma to use for patients who might require maybe fibrinogen, maybe factor VIII if we don't have specific clotting factors available readily. Multiple patients actually, a single unit can help up to 4 to 5 patients. This is the.
oh, very nice. Thank you. That was very lucid. Now, you had mentioned that even if 1 to 3% of our population donates blood, we would be able to meet our needs. So, who are the people who can donate blood? Can you tell us what is an ideal blood donor? And I believe that there have been some revision in the guidelines for people who can donate blood.
Yes, ma'am. There are actually different kinds of revisions. One revision is given through the Drug and Cosmetics Act. So that that holds good actually. It's a mandatory thing. And we have one more kind of revisions that are being given by NBTC periodically. So the last NBTC guideline is somewhere it was released in February of this year. So currently when we try to make guidelines, our SOP, standard operating procedures, we try to match both of these so that we will not be in legal obligations also, and similarly from NBTC guidelines also, we want to be on safer side. But both of them are almost same. Like the donor's age should be between 18 to 65 years. If it is a regular repeat donor, he can donate up to 65. If it's a first time donor, they can donate up to 60 only. For SDP, I think it is 60. The weight of the donor should be more than 45 kgs. For simple whole blood collection, if it is SDP collection, it should be more than 50. If we are trying to collect double product, it should be more than 60. If it is 450 ml blood collection, it is 55. So hemoglobin level for all is 12.5. It should be equal to or more than 12.5 grams per deciliter. They should not be having any med issues, especially it can be fever, cold, cough, any kind of severe health disorders also, like it can be heart disease. They should have had at least 1 day good night of rest actually, and they should have had something in the last 4 years before donation of blood. This is to prevent complications of hypoglycemia. It can be different kinds of complications can happen. It can be vasovagal syncope, it can be anything. And if I have to say the specific differences between the older guidelines and newer guidelines, I would say now the newer criteria has friendly for even differently able donors. Like they have permitted donors with communication side difficulties also to donate blood, provided they can give uh, consent. Confidential communication can be given, and they can provide consent. Similarly, they have given newer criteria as to what is the weight of donor for doing platelet pheresis, red cell donation by apheresis. They have changed the gap after platelet donation also. Before it was 28, now it is 7. Uh, Similarly, there are changes like patients who are euthyroid with medication and with no dose adjustment in the last 8 weeks, they can donate blood through NBTC. Previously, they used to be deferred. And if we want to collect a double red cell apheresis donation, now this time they have set specific guidelines like the hemoglobin should be more than or equal to 14 grams per deciliter. Internationally, it is 13.5. In India, there was no such guideline. So we used to follow international standards. But now this time they have set a higher value for us with a 14-gram hemoglobin. And similarly, they have given guidances saying that above which level we should not take blood from a donor. Like, for example, if it is a male, it is more than 18.5 grams. If he is having, he should be suspected with maybe possibly polycythemia vera. It can be secondary also, but either way, we have to exclude these donations. If it is female, if their hemoglobin is more than 16.5 grams per deciliter, then also we have to exclude them. Attending to occupation also, this time they have given specific guidance stating that if the person who is coming to donate blood, if he's an air crew member, it can be pilot, co-pilot, or long distance vehicle driver, or people who are diving, or teaching swimming in swimming pools, they can only donate blood if they had good night of rest, and they should not be resuming their work at least in the next 24 hours after blood donation.
Okay.
So like this, many criteria has been given. Even people who are taking material, like previous guideline states for 2 months, actually we could not take them, we cannot take them. Now the present guideline states that if they have taken radio contrast material for non-malignant conditions, the deferral period is 6 months. If it is malignant condition, we have to permanently defer. Even hair transplant, PRP therapy, skin grafting, they have given deferral period of 6 months in the latest one. Convulsions, epilepsy, who have been off medication or seizure free during the last 3 years, they have been permitted now.
Very interesting. So this was a very exhaustive and very detailed list of people who can donate. And I think this should motivate more people to donate. So sometimes there is a hesitancy to donate because people are afraid what is going to happen. Can you highlight what are the problems that can be seen in voluntary blood donors?
Blood donors, actually, they do rarely face some problems, ma'am. These problems are most often preventable. Like, for example, uh, most of the reactions are of mild nature. The donor will not be losing consciousness also. These may include like small hematoma formation locally. It can be allergic reaction as manifested by urticaria when we are cleaning them topically with spirit betadine or maybe chlorhexidine isopropyl alcohol. So all these things can be managed at the blood collection site. But what we have to ensure is the donor is a person. He is coming with an altruistic motive to donate blood for some unknown patient. Maybe they may be just donating even without knowing the patient. So we don't want them to go into problems. It can be syncopal attacks. It can be even after donation, maybe after one day also, they may have problems. So we don't want these things to happen. So we try to educate them properly. Just before donation, we usually use different techniques like applied muscle tension. Before we do a phlebotomy, we ask them to take maybe water, maybe buttermilk, maybe ORS also. If it all depends on how the person is there. If we find a replacement donor who is so tense, who is coming to donate blood, we have to definitely let them cool down so that they will be anxiety free. So that is the main basis, I should say, ma'am. But vasovagal syncopes also happen to people who are anxious. Suddenly they may go into different kinds of phases of reactions are there. They may even throw up, actually, they may have nausea, they may have vomiting. So whenever these things happen, we have to take care of the first aid, local first aid. We try to uh, elevate
So
the
blood donation
legend of
is
the
very safe on the whole. Sometimes minor
yes, ma'am.
issues can happen, usually because of stress. That is fantastic. So sometimes we have patients who donate regularly. In fact, we often have, at least at AIMS, we have some donors who we have given because they are really, regular donors. So is that something that should be recommended?
Yes, ma'am. Regular blood donation is definitely a boon for us. It's a boon for the donor also. Regular donation, actually, it has many positive effects on the donor. Especially, this is only, I'm saying regular blood donation, because regular blood donation has been proven to reduce cardiac outcomes, adverse cardiac outcomes by 2 to 3 times. So they are less likely to get maybe heart attack, maybe stroke. Similarly, there are some studies actually that even show because of regular blood donation, lower iron levels may reduce oxidative stress, potentially giving chance for maybe cancers also. So I don't find, I could not find actual exact proof, but there is some people they say that it can reduce cancers also. In addition to this, there will be iron regulation in these patients. Blood donation act itself serves as a physical health checkup for the donor. So if they have any diseases at that time, they can be sent for treatment at the earliest in the initial stages itself. So their health will be better. And even after blood collection, infections, it can be HIV, hepatitis B, hepatitis C, syphilis, malaria. We'll be sending them to confirmatory centers actually for further management and treatment. So in some centers, actually, these things are being done in the transfusion medicine department also. So this also plays a role in developing or elevating their problems in the future. It will help their health.
Very nicely said. So not only are you getting blessings from helping people and saving lives, but it could actually benefit your health by reducing cardiovascular risk, oxidative stress, and so many other factors. Very nicely said. The person who is receiving the blood, they often are very afraid. And what are we doing in transfusion medicine to ensure that we have safe blood? There's often a quotation that they said that safe blood starts with me. So what exactly are you doing, and how can people be sure that they are getting safe blood?
This is a tricky question, ma'am. In a way, there is no such thing called safe blood. In even in developed countries like USA, they always advocate that don't take blood from us. Blood transfusion has to happen only if patient is going to die without blood transfusion. So it's a matter of weighing the risks and benefits of blood transfusion. Especially the main role of blood transfusion is maybe in trauma, maybe in surgical cases where there may be surgical sudden blood loss actually, when our body system is not able to compensate for acute blood loss. So in those situations, if we are not going to transfuse the patient, they will obviously die. It can be increased mortality, it can be increased morbidity. It's all it all depends on what the patient's condition is, whether the benefit of transfusion outweighs the risk of transfusion. And we always try to go for patient blood management. We try to involve the patients also in informed decision making. So the patients also have the right whether to go for blood transfusion or not. All these are part of bigger clinical management picture.
Thank you. You've given a wonderful explanation of the difficult questions, and we thank you for your expertise. Um, I now have some questions for Dr. Gopal Patidar. Dr. Gopal Patidar is additional professor in the Department of Transfusion Medicine at AIIMS, New Delhi. So welcome. It's such a pleasure to have you here, and we would like you to enlighten our audience. So, Gopal, we had been just talking to Dr. Chaitanya about safe blood. So, how do the blood banks ensure blood safety when we have donors who are coming from all over the country? Sometimes they come in because relatives of ours, sometimes they're already donors. So, what are the tests that filter this to make sure that the blood that we have in our blood banks is the safest it can possibly be in today's day and age?
Thank you, ma'am. So the safe blood journey out the testing of the blood in the blood center are the multiple steps, you can say. It starts with the donor itself, like Dr. Chaitanya has explained very well about the donor selection criteria as per the Drug and Cosmetic Act as well as the NBTC guideline. So if we select the donor, a healthy donors with the qualified first and foremost steps of the safety of the blood, we qualify from them. Then after collection, there is the processing, like component preparation and the storage of the blood. And there also is safety is concerned based on the aseptic processing, like the person who is processed or separating the component from this blood and as well as the store the blood, maintain the proper aseptic conditions. So that can save the blood from the contamination, bacterial contamination or the environmental contamination. Then after that, we perform the testing of the transmissible infectious disease. Like in India, we are doing for testing for the HIV, hepatitis B, hepatitis C, malaria, and syphilis. These five tests are the mandatory in the as per the Drug and Cosmetic Act in India. So we are performing the testing of this for blood of the donated blood from the voluntary blood donors or the other blood donors for these five diseases. And with the advanced techniques like ELISA or the chemiluminescence testing, or nowadays with the nucleic acid amplification testing, we are ensuring the safety of the blood. And finally, the safety ensured at the time of the issuance of the blood, the proper as well as proper blood grouping of the patient and the donor. So this final step of the safety to provide the final before transfusion for the safety of the blood in that.
So you mentioned many techniques for testing. We now have something called NAT Tested Blood. What does that mean? And that is not available all over the country. How do you think we can expand this to reach more and more transfusion centers?
Thank you, ma'am. So NAT testing is nucleic acid amplification testing. The traditional testing in blood banking we are doing is the serological testing, in which we are testing the antibodies of these viruses, which are comes up and after infection into the an individual body. But it takes some time. It is called the window period. Is whenever infection and then these and antibodies or antigens appears in the body, it is the some period in between that is window period. The window period for the serological testing is longer. So to reduce this window period, nowadays we are performing the nucleic acid amplification testing. In nucleic acid amplification testing, we are directly testing the DNA and RNA, the molecular structure of these viruses. So this molecular DNA and RNA of this comes up much earlier as compared to the serological marker like antigen and antibodies. So by reducing this window period, we are able to get the identification of these viruses in the donor's body as soon as possible they arrive in that. So by that, we can improve the safety of the recipients whenever they receive the blood transfusion in that way. Yes, you rightly mentioned that there are very less number of the centers in the country who are performing the NAT testings because first and foremost is the cost is involved is in this test as compared to the serological testing. It is more so in that way, if the government is supporting the blood centers or government is making a centralized testing centers for this net testing of the particular area, particular region or that city, or in some states are doing nowadays the centralized net testing in their state. So in that way, we can improve the net testing centers in the country and we can ensure the patient safety through blood transfusion in that way.
Okay. So is this like a pooled NAT? Is that what you're talking about? When you
No, ma'am. There are the NAT testing in the country currently. It is pooled sample in which they are pooling the sample seats or 16 or some 90 seats in different on the different centers. And one is individual NAT testing in which each testing individual is we are doing individual, each sample is testing for the nucleic acid amplification. So there are both kind of the testing available in the countries, and till now there is no net to net comparison of this time which is one is better and which one is not better. So we can perform both the testing. Anyhow, they are performing better safety as compared to the serological testing we are doing traditionally.
So there are some patients who get blood transfusions, like patients who have thalassemia major or aplastic anemia and other patients. So how can we prevent reactions and other things that happen in these patients who get frequent blood transfusions?
Yes, ma'am. The frequent blood transfusion or chronically transfused patient, you can say these hemoglobinopathy patient like sickle cell anemia, thalassemia patients. So in on frequent blood transfusion, there is possibility of the several adverse transfusion reactions. The most severe and common adverse transfusion reaction, you can say acute hemolytic transfusion reactions. And then further is the commonest is the febrile non-hemolytic transfusion reaction or allergic reactions or some other reactions like transfusion associated circulatory overload, transfusion associated acute lung injury, and etc. So for minimization or prevention, the better thing is for the acute hemolytic transfusion reaction. You can say it is because of the primarily because of the ABO incompatibility, and that is because of misidentification of the patient. Sometimes this kind of the patient come up into the emergency because of some complications, and they need the blood transfusion. And in emergency, if there is mismatching of the blood sample, and it can lead to the mismatched blood transfusion or can ultimately lead to the ABO incompatible hemolytic transfusion reaction. And for that, the patient identification is important, the proper documentation is important for that way. And other reason of the acute hemolytic transfusion reaction is the alloimmunization. This kind of the patients are much higher prevalence of the alloimmunization as compared to the normal patients because of the regular transfusion in that way. So that the right testings of the patients, like for the allo antibodies, as well as the pre-transfusion testing for the pre-transfusion phenotyping of the patient is important in that way. Then the further common as adverse transfusion reaction in this kind of the patient is febrile non-hemolytic transfusion reactions. This is because of the WBCs or leukocytes present in the blood components that can lead to the febrile non-hemolytic transfusion reaction in that way. For that, the nowadays the leuko reduction is kind of the available in the many of the centers, and pre-transfusion to the transfusion associated circulatory overload because of the multiple component transfusions or chronically transfusion. There is possibility of the circulatory overload or in this kind of the patient. For that, the pre-transfusion diuretics we can provide or the initial use of the right blood component is the better way in that way. So there are the multiple measures of the to prevent the adverse transfusion reactions here. Ma'am, you are mute.
I think Madam's connection might have been disconnected.
Okay, hello. Sorry,
Yeah,
I'm back.
yes,
So wonderful. You were talking about alloimmunization. So I think I missed. Did you talk about extended typing for patients with thalassemia and sickle cell?
yes, ma'am. I talked about that before.
Okay.
If possible, the before first transfusion, it should be do the extended phenotyping of this kind of the patient. Because on regular transfusion, it is difficult to get the exact phenotyping of this patient. Because minimum it's required 3 months interval between two transfusion to get a better phenotyping of the patients. So if some patient come to our center at the first time or he has not received any transfusion and just diagnosed for that way. And so before first transfusion, if we are performing phenotyping like RH blood group system, then KL, EID, MNS, all these minor blood group antigens we type before that. So we can provide a type match blood in that patient. that will help us to reduce the alloimmunization in this patient, as well as easy to identify the blood if in case future they have some kind of the alloimmunization or an alloantibody in that.
And what about filtration of blood?
Yeah, it's a leucofiltration, like I mentioned in that way also. The leucofiltration, we pre-transfusion or pre-storage leucofiltration, we can say that is better in nowadays. The leukofilters are usually attached with the blood bags, and we leukofilter before storage of this blood. Leukofiltration helps in the reducing the febrile non-hemolytic transfusion reaction, because most of the leukocytes can lead to the febrile reaction in chronically transfused patients.
So for thalassemia and sickle cell patients who get regular blood transfusion, you feel that they should get pre-storage leukodepleted blood?
Yes, ma'am. So in this regularly transfused patient should get the pre-storage leukodepleted blood. So there this kind of febrile non-hemolytic transfusion reaction or some kind of the alloimmunization, natural alloimmunization, or CMV infection can prevent with this leukofiltered blood.
Right. And in fact, at AIMS, our patients are receiving this and they're receiving it free of cost. So we're very, very grateful to our transfusion medicine colleagues for the excellent care that they get. Now, what about in trauma or accidents when patients need massive blood transfusions? Is the strategy for giving blood a little bit different? Do we need to add on any components or anything for these patients who have trauma?
Yes, ma'am. In trauma cases, there are the severe blood loss in these patients. So this severe blood loss can lead to complications like hemorrhagic shock in these patients, then hypothermia, acidosis, and coagulopathy. So this like massive blood loss, you can say, or massive blood transfusion when they require the massive blood transfusion. There are different definitions for massive blood transfusions, like more than 10 units of PRBC transfused within 24 hours, or more than 4 units of PRBC transfused within an hour, or replacement of more than 50% of the blood volume, or more than 150 ml per minute of the RBC transfusion in this kind of the patients. So this massive transfusion can further lead to the complications in patients like acidosis and coagulopathy. For this, we have to assess the proper requirement of the blood. For that, we can do the point of care testing like thromboelastography testing or the ROTEM testing. This kind of the testing, we can identify the what right component is required to these patients. The primarily components which required to these massive transfusion patients are PRBCs because of the blood loss, then the platelet concentrates, then plasma. So the ratio of these components is also important in these massive transfusion cases. Like internationally, it is quite acceptable ratio of 1:1:1 of the all three blood components is transfused simultaneously. Then, because of the massive blood loss, there is a higher probability of the hemorrhagic shock in this kind of the patient. The rapid availability of the blood is also important. So, like in our trauma center, also they prepare the massive transfusion protocol specifically. So, whenever this kind of the patient come in our trauma center or in emergency, they activate this massive transfusion protocols. In massive transfusion protocols, like in first initial stage, they provide the blood based on the initial blood group, non-blood group, or if blood group is not known, then a universal blood like for PRBC or RSD negative or positive, whatever is available in the stock. Then for platelet and plasma, AB, RSD positive components are provided. Then whenever the blood group of the patient is known, then the blood group matched blood will be provided to this patient. So this massive transfusion protocol is quite much important for in any trauma centers or in trauma emergency cases in that way.
I just saw in the questions, there was somebody who was asking about whole blood in trauma. So did you want to just take that question?
Can we take the
in
questions
case of
later?
massive okay.
Can we questions later? At the last, we'll have after the sessions.
Okay, thank you, Dr. Gopal. That was really lovely. Please do stay on that we can answer all the questions that we have later. Yeah, thank you so much.
Thank you,
Very,
ma'am.
very good comments. Thank you. So we now have Dr. Vijay Kavat, and we are delighted to have you joining us from Bengaluru, where you are HOD of Transfusion Medicine at NIMHANS. Welcome.
Thank you, ma'am.
So I wanted to ask you, What is the government doing to give more information about blood availability? Because sometimes we hear stories of patients going to a blood bank, there's no blood available. So is the government doing anything to address this problem?
Yeah, so now Government of India has taken initiative. It's a quite long time e-Rakta Kosh portal. So now that is the single solution for everything. If you want to donate blood, you can find out the nearest place where you can go and donate. What is the availability? You can search for component wise, whether PRBC, platelet, the nearest blood center which is available. And if you are interested, you want to organize blood donation camp, there also you can register with that camp. So uh, as of now, earlier various states also have their own uh, support system to make that availability of blood. But e-Raktakosh is now a portal where it's a web-based and app-based also, both on iOS and Android it is available. So anyone can download, install or browse e-Raktakosh and find out. Uh, so it's a like compliance is still it's increasing, but all blood centers are supposed to update their blood stock periodically based on the uses. And once it is adopted live, I think that live stocks throughout the country must be available. That I can see the future of this portal.
Oh, that's very good information. So, what would you say to somebody who is not sure if they want to become a volunteer blood donor? How can we motivate such people who are
Yeah, so motivation is like somewhere in 70s we started our voluntary blood donation movement with Dr. J.R. Jolly, who, like whose birth anniversary we celebrate as National Voluntary Blood Donation Day. So from the day, from those, I think nearly for almost 50 years, we have come forward quite a lot. As Dr. Chaitanya has covered that we are touching nearly and few states are passing that our calculated requirement. But still, I would see the challenges are the disparity of availability of blood. In metros and some states, situation may be good. So we need more motivation uh, on the ground level, more participation of various NGOs who are already working so many organizations to promote voluntary blood organizations. But I feel somewhere the success stories and all, because if you move to urban areas, people want to know that what is happening with this blood. So at as of now, because of lots of confidentiality issues, we are happen to this blood exactly. But at least on a broader term, it can be shared in some way. Earlier, the thalassemia campaign used to come that "Karke dekho acha lagta hai." Na, that kind of the on the print media, in digital media, in social media nowadays, I don't see much of the IEC material which is available. So we have to push it more and more again.
very good points. Now, what should be the estimate while looking for advanced practices? Would it be good to adopt the NBTC processing charges for blood components under the PMJY?
Yeah, so the costing of blood product, now there's a streamlined process. NBTC has a task force which meets, supposed to periodically revise every 3 years. So last, I think we had in 2022, the revision. So they account for all costs which is involved in producing a blood component. So under PMJ, if I see, there are only two way. Either there is a tariff, whole blood tariff, and one component tariff, which includes all components. So where I think the costing amount is somewhere around 2,000. So again, personally, I feel there should not be disparity between with the same ministry, two different program advocate that this is the cost and this is the cost. And so it can be streamlined. Then we have spoken about leukoreduction. We have spoken about antigen matched blood. We have spoken about possibility of introducing chemiluminescence, nucleic acid amplification testing. So there's a tariff decided. So still all blood centers across the country are not at the certain level. So those who are offering certain advanced technology, they can avail that benefit through that reimbursement process. So NBTC has included them. And then for apheresis product, though in hemoglobinopathies, we don't see in routine care use of apheresis platelet, but for advanced treatment like for transplantation and all, lots of peripheral blood stem cell harvesting, the single donor apheresis platelets and all. So that tariff also has to come. We know that cost is quite high. So NBTC also be around 11,000. So it's a good if we can adopt and give wide probability. Apart from that, blood products are not covered under PMJ. So I would also request that various blood products like the albumin, the uh, other blood disorders where you need factors, factor 8, in trauma, if recombinant factor 7 and prothrombin complex concentrate, fibrin sealant, we extensively use for neurosurgical procedures. So if those things also can be included, so that would be better helpful for wider care which we can provide to the patient population.
Good point. So, how do you foresee the future? We have many large private hospitals and clinics coming up. How can we encourage them to also take care of patients with hemoglobinopathies, which has so far been the burden of the government hospitals and some NGO hospitals?
So with the current healthcare industry structure, which is like very fragmented and divided into government and private sector, so the ultimate aim for is to improve overall health of our population. So I personally feel that it should be inclusive. Those who are willing to participate, either maybe some NGOs or private health organization, they should be also provided. Only the problem or hesitation I could foresee is the financial aspect, which if it is covered under, because we are running national programs for various, under which majority of the time various government hospitals are only taking care. So just for a simple example, for a blood transfusion, why should a 10-year age or girl of 10-year age should come every month or every 2 or 3 weeks, 200 kilometers just to get 1 or 2 unit TRBC transfusion? So if we can empower the taluk level hospital or the taluk level, if it is some private hospital also, which they can source blood from some mother blood center, they can serve as a storage center and provide transfusion there. And now with the use of technology, if any tertiary care level intervention or advice is needed, it can be quite easily done with the telecommunication or teleconsultation. We are running Telemanas quite good, and we are offering teleconsultation to wider population. So that I can see. So overall, if we include all NGOs, it can be a better thing for prevention and screening initiatives, because I was discussing with one of the NGO, they say that under PMJ, there is no package where if I am doing 5,000 screening for antenatal women, how can I get some financial support? So if that mechanism also can be, then community-based care, which has been established like Thalassemia Society of India, they have taken for decades and decades. So where we are for the community care for thalassemics, and many tribal organizations are working for sickle cell. So that their inclusivity always is going to wait, because they can play a major role in advocacy. So that is also now we are coming up with the various patient advocacy program where patient also has to say that what is their need. So a need in Bangalore may be different in Kolar, which is a rural area near the Bengaluru, or the requirement of patient in Andhra to Himachal Pradesh may be the different. So we should look forward active participation of all holders, whoever is willing, and we can add up by facilitating it.
Yeah, very good suggestions. I think that's excellent. And I do hope that some of these suggestions can be implemented soon. So, do you think there should be any breakthrough in blood advancing practices for patients with hemoglobinopathies and others who are requiring blood transfusions? Anything new on the horizon?
Yeah, so it's a continuous process we have to go through. So many things we have tried, but the sickle cell or for thalassemia, the aluminization, catering the aluminized patient is quite difficult, challenging task. Even I'm sitting in Bangalore, but I knew that only 3 centers can perform extended red cell phenotyping. And if needed some genotyping in difficult cases, it has to go to NIH Mumbai, which takes time. So the capacity building for at least for serological investigation, followed by extended if blood group genotyping. Though I know that AIMS and other premier institutes have already taken initiative, but it can be maybe a referral kind of model where the turnaround time can be reduced. So if I dispatch one sample, once referral lab receives the sample, I should get within 24, 48 hours some preliminary information what we are dealing with. Now then AI is coming up. So in transfusion also it's quite good applications which can help for inventory management. So in blood stock where we talk about we are deficit, the definitely the wastage, the leak in the system also plays a major role. So at national level, we need to streamline our wastage, what is happening, which may be different from a tertiary care center to a storage center which receives blood. Still, I know many clinical specialty, they don't want blood within the last 7 days. Okay, so that may be actually, so that we can put up better inventory management system. Then the smartphone-based diagnostic tools which are there, which can be incorporated with point of care testing, maybe for some initial screening, which is easy to adopt. And again, the centralized data can be analyzed. That I foresee a few advantages which we should work about. Leave about gene therapy and all that. Those things may come up, but the grassroots level which can help us to screen, identify, and guide them and the follow up. Because antenatal screening was done once, but after that, we don't know that family decide to conceive after 4 year or 2 year down the lane because lots of social pressure. So they have gone through. We don't know. Then again, that kid or that neonate comes again and see. So the effort which was taken in preventive strategy, just because we have follow-up mechanism, but it can be more robust. So we should strengthen our follow-up mechanism for maybe the social workers, like what we do for mental health. Our psychiatric social team, they visit community visit regularly, follow-ups and all, something like that can be devised.
Yeah. So yeah, thank you. So thank you. I think that's very good. I thank you for your valuable suggestions. This was excellent. I'm sorry, Dr. Gopal Patidhar, there was one question I think because of my technical issues I had forgotten to ask.
Yes.
Dr. Gopal, can I ask for you to come back?
Yes,
So
yes,
sorry.
yes, yes,
So,
ma'am.
another issue that is sometimes happens, but is a very big emergency, is patients who have rare blood groups. So, how do we manage such patients with rare blood groups? And are there any systems in your transfusion medicine that you can enlighten us about for patients with rare blood groups?
Yes, ma'am. Sometimes, like majorly the blood groups is divided into the ABORH, which is common, and the other rare, like minor antigens, against which the antibodies should be prepared. And sometimes blood required for those kind of the patient is quite challengeable for the transfusion medicine department also. So in that case, we usually try to keep our center specific rare blood group registry in which we keep our type, our donors regularly, like RH cell typing, we are doing almost 1 to 2% daily donation. RH cell typing we are keeping, and we are keeping registry for that things. In some cases when there is the severely rare body is detected in patient and we identified the donor for that case, we also keep the registry for those kind of donors also. There is also initiatives is in nowadays in the there is the centralized rare blood donor registries is coming up. In that way, we can get a blood from the other blood centers also who have those kind of the blood in their inventories. As well as we also in some cases, some specific cases, like recently we received a request for the D-dash test, which is very rare in the India. In that case, we contact with the internationals also, and we received the blood from the Japan for their questions specifically. So that kind of the quality work is required for the getting blood from this for this kind of the patients in that way.
Again, the connection is gone. I need to check her with.
We
Yes,
can.
I think.
So actually, it is really nice to hear all of you. There are certain other questions which I have to ask ma'am about the basically stem cell transplant, being a hematologist, because the other hematologist, Dr. Vikram, couldn't come up because of his some emergency issues. Good to learn. Actually, I've been working at NACO and then at NHM at Blood Cell. And after that at Tribal Affairs, I've been learning these transfusion medicine from a very long time and from you guys only. But it is very interesting to learn many other things which are coming up. And with that, actually, we wanted to talk about the stem cell transplants. Actually, whether because we are, if you see the earlier days, we have only some centers. Yes, ma'am, we lost you.
Sorry.
So, the concern is about stem cell transplant, which is very important. And now earlier we have only 5 to 7 centers. If I remember in 2016 we had 35 centers, and now the centers for stem cell transplants are 165 across the country, and it is increasing every day. So when we talk about stem cell transplants required, and ma'am, this is a question for you. No, doctor, I will request Dr. Tulika Singh to answer this. The stem cell transplants requirements are quite different, ma'am. And in India, we have an infrastructure to deal with the same. Is it there?
Yes, we do have good infrastructure. In India, about 5,000 to 6,000 allogenic bone marrow transplants are performed every year. We have several hundred good centers that are able to perform these procedures, and they are equipped with hematologists, excellent transfusion medicine support, and all the other requirements. So it has taken time, but at the moment, I would say that we are in a good position, and in future, more centers will be able to perform even more numbers of transplants.
Concern is, ma'am, because we are having a medical tourism which is going high in the country. And many people are coming from the other countries to get transplant over here. How do you say that the medical tourism, do we need to have some SOPs for medical tourism specifically concerned to these transplants? So that is a challenge for us. And this we have been hearing across many workshops, many conferences that this is a problem. How do you say about that?
So my personal belief is that we should have SOPs for everything. And even medical tourism must be done in a very good way so that we ensure that the patients, even the patients who are coming from abroad, they should get full benefit, and good follow-up of these patients should be done to ensure safety and to ensure the good reputation of the Indian medical facilities and everything. So I really recommend that we should have some guidelines in SOPs.
Ma'am, the plasma and plasma products, because we have a hemophilia program in the country, and plasma is one of the component for blood. So when we talk about plasma, the storage of plasma is a very important thing when we do it. And standard medical conditions, we required plasma protein concentrate, nose and plasma derivative. Which plasma is supposed to be good, ma'am, and for plasma products we see? How do you say
So,
about the plasma which we are having? Do we have good enough? Because plasma fractionation center are very limited in the country. So we want to know about that. Which is the source?
so there are many good centers like our AIMS New Delhi, where all of our blood is NAT tested and it goes through very rigorous screening, right from the selection of the donor and follow up of the donor and all the blood testing. So there are many companies which are now taking the plasma from centers like ours and other good centers, and they are using this plasma to create Indian products of like fibrinogen concentrates, factor concentrates. And I think this is the most important. As long as you are sure that the source of the plasma is good, then if you do the further processing, you will end up with very safe products. And in fact, many of these companies that are taking plasma from us and from other large, good blood centers, they are now even planning to export some of these products. So I think it's a collaboration. And if we have more and more good centers in the country and more wonderful volunteer donors, we will be able to produce enough of the plasma products that we need in our patients and not have to depend on importing these products from abroad. Ultimately, safety is the most important thing. There are recombinant products which are also good. So I think that a good recombinant product and a good plasma product for hemophilia are equally good. The main thing is that whichever product we use should be a safe product.
Ma'am, here I will connect to Chaitanya also. Chaitanya, I want to like to know when ma'am is saying the plasma source should be good. So how do you say about the plasma source? How much time it should be done? Like you said that FFP has to be kept for 1 year. But do you think the
Yes.
plasma which we are sourcing, the products the yield of the plasma should be very good. That is what I've been hearing from you people. And the yield of the plasma and I have learned during my tenure in working for blood services and at NHM and NACO and even at the Tribal Affairs also. So, how do you say that? What are the requirements where we can have a good plasma? Yes.
Assessment of quality of plasma is a tough challenge, ma'am. Especially if we see the latest DGHS technical manual of several criteria for assessment of plasma, including appearance, everything. But if we keep that aside, also there are many standards that have been set in DGHS technical manual. Like for example, we have to prepare plasma within 6 hours after blood collection, and we have to shift it to a deep freezer, maybe -40 or -80. It should be less than -30, and this has to be the temperature of the deep freezer has to be maintained and monitored. If there are centers where there are frequent power cuts, even the temperature be fluctuating. So these things are there. In addition to this, the quality control parameters like maybe factor 8, fibrinogen is a mandatory test now for in all blood centers actually, and we have to assess factor 8 and other clotting factors also regularly for FFP. If we see international level usage of plasma, most plasma fractionation centers in developed countries, they take plasma for as a source for plasma fractionation only after 3 months, or I should say, when the donor who has donated plasma in the previous cycle, if he comes for donation this time also, and in these 2 cycles, if he is negative for HIV, hepatitis B, hepatitis C, even through NAT, then they will take the first unit for plasma fractionation actually. So this gives better safety for patients also, recipients also, pertaining to products, plasma products.
Thank you so much. And when we
Thank you.
talk about these special, like we were just talking to ma'am about the stem cell transplant. So we need special procedures for HSCTs, hemolytic stem cell transplant. So stem cell harvest is one of them, which is being done in the blood bank. Ma'am, this is for you. So, what do you say? Do we have good stem cell harvest facilities? Because all the blood bankers are also there. Apart from our aims, Gopal is there that he might be understand. So, do we have that facilities of stem cell harvest across the country?
So the majority of hematopoietic stem cell transplants done nowadays are peripheral blood stem cell transplants, and for that we require apheresis product. The apheresis product can be done on a donor who is matched, or it can be done on the patient if it is an autologous. And most of our transfusion medicine colleagues are experts at apheresis because they do apheresis for platelet collection and for other procedures. So now I believe in fact, even the rules state that the apheresis collection should be under a blood bank, and that is how we are following it at our center. And our blood bank and transfusion medicine colleagues provide us excellent support in both the autologous as well as the allogenic of the apheresis products. Along with the transfusion medicine team, we also require laboratory supports to do the CD34 enumeration. And some of the centers are also doing further processing of the product, in which they can do TCR alpha beta depletion or other requirements. And with that, sometimes we may also need cryopreservation of the product if the transplant is to occur at a later time. So altogether, it's a teamwork that's set up, and the majority of the transplant centers in India have gone ahead and created these teams where everyone works together, and with that only we are able to provide the hematopoietic stem cell transplant, because that is not something that can be done by an individual. It really requires a very good team, and with that team support, then the patient benefits. And we have that, as I said, our most of our transfusion medicine colleagues are able to do this, and I think we can have more and more centers in the future.
Ma'am, thank you so much, ma'am. And just Vijay, Dr. Vijay, want to know about, do we have that facility in Nimhans also, or some, I mean, in not in Nimhans, but in Bangalore itself, in the government hospital setup? Private, I do understand, but in government setup, I'm asking.
Government setup, it's in the beginning. I'm not sure about the state government, but NIMHANS, because we are mental health and neuroscience, so we don't have facility. But apheresis we have, apheresis we do. Anytime if needed, we can also do hardware. So because we do lots of therapeutic plasma exchange, so we do 16 apheresis equipment in my blood center.
Because day by day these centers are improving. I just wanted to know how much our blood banks are equipped with that. That is very important. When ma'am said it is a teamwork and it is the transfusion medicine people who are going to take care of these things. So we would like to know how many blood banks are equipped with this, because day by day the transplants are going up. And when we are talking about medical tourism and other things also, it is important that we should know that what exactly where we are. So that's what the question.
Most of
And
urban,
yeah, please.
yes. So most of urban areas, they have facility to collect PBSC at least. Okay, and Bangalore is one of the biggest center in country for medical tourism, as for also for bone marrow transplant. Okay. So like NGO for thalassemics, I don't think any center throughout the world is doing the number of transplants which Sankalp India Foundation is doing with hospital. In 2 years before, they had done around 500 transplants. Recent figure, I don't know.
The
And
transplant
so,
centers we know because we started with the Thalassemia Bal Seva Yojana from Ministry of Health in 2017 onwards. And we had
yes.
done a lot of transplants. I understand that states are there. I mean, these facilities are there. But if we, as I said, as we are hearing out that it is coming up, it's coming at, now we need to have those facilities everywhere. That is the concern, especially in the tertiary care. And if they want, our people want to refer our CSC, and referral systems are very important, I think so, because you can be a hub to the people at CSC and PSC where we have storage centers. Then now I mean, there is a thing which has come up that there will be basically analysis of the blood services, what exactly is happening across the country. It will be very helpful. The government has taken up this issue and it will be done in some centers. So we will take up the storage centers as well as the district blood bank and also the medical colleges. So now we have some questions, and ma'am, can I basically it's in the chat box. Does autologous blood collection need license? Chaitanya, this is for you. Does autologous blood collection need license?
Blood collection definitely needs license, ma'am, but the documentation has to be different. It's an autologous procedure. We can also label it as a therapeutic procedure. Just to purchase blood bags or consumables for apheresis, actually, we need to have a license. That is why for whole blood collection or packet cell collection, if we have license, we can collect autologous blood and process it as a autologous collection.
One question is very interesting is for any single condition, for instance, criteria differs in Drug and Cosmetic Act and NBC New Year guidelines. In that case, what should we do?
The drug
For all
inspectors
of you,
who
ma'am, including you. Yes, please. I mean, there are
everything in black and white.
so there
So
are
it is they follow DNC Act only. There are some guidances actually in the new Drug and Cosmetics Act which states that we have to follow, like if DNC doesn't say something, we have to follow the DGHS technical manual. So the latest DGHS technical manual also has mentioned many things. So if we follow those things, it is okay. If the drug inspector is not kind enough to permit us to follow the latest NBTC guideline, we will be in soup. That is why we have to ensure it depends on the local situation, how far the local drug control administration knows about this criteria. That is the main point.
very interesting question. If anemia definition in men is hemoglobin is 13 and why HB is 12.5 is expected for blood donation. Are men in 12.5, 13 range not already anemic due to donate blood? Anemic to donate blood?
No,
They are
anemia
anemic.
in men is not 13. Who says anemia in blood is 13? The anemia definition is the same. We have to follow the WHO definition, and WHO definition is 11. Yeah.
This is again Dr. Gopal or Dr. Kumawat can answer. Awareness campaigns about importance of blood donation are required. Madam Shobha has said that. So I think this is important because we all understand until we do a good awareness campaigns, it is not possible for us to have good camps as well. There is a question, ma'am, is harmonious reading of 2025 NBTC and drug and cosmetic means taken a higher cutoff when comparing both. In 2025 NBTC guidelines are legally binding as NBTC got deleted powers vested by TNC. Can you comment on this? So anybody from the blood bank can comment on this. Hope you have read the question.
Yeah. So
Yes,
I would so I would say, because the NBTC guidelines are given by the experts, okay, and it is from a government body which is directly under DGHS. So there should not be no ambiguity that if something scientifically has put up by a expert group, we should not have binding. Okay. So it should be like we can educate our authorities wherever there is a conflict. There's nothing wrong in following NBTC guideline or DGHS technical manual. As Dr. Chaitanya also told, that DCA also says that if there is a doubt, you can follow the DGHS technical manual or any other standard book. Okay, even if it's mentioned. So it should not. It's up to us what we want to get follow. Leave about that what happens and all. Things definitely change, but it takes time. It takes on. So that's what we should start working towards. That this notion has to go, that this is what is acceptable, this is what is not acceptable. It has to be based on scientific sanity and rationality.
So
Yes, ma'am.
And Dr. Vishwas Amin has said with the centralization of blood banking. Dr. Gopal, if you can answer this, is helpful. Dr. Vishwas Amin is from IRCS Gujarat. He takes care of Gujarat IRCS blood bank. Is helpful to improve quality of blood, reduce replacement blood donation, and easy availability of blood to patients. So
Yes, we
Gopal,
can say that centralization of blood blood donation. It's mostly the concept in the Western countries. Most of the Western countries have their centralized blood donation. In India, like looking the geographical area of the India and the quite variability is there. Yes, you can try at the local level. At local, some of the centers can do a collaborative blood donations as well as the component processing. It will help in the improving quality, no doubt, because of there is a harmonious improve quality parameters between all the blood centers at one. So it will definitely help in the improving the quality of the blood and blood components in that way, as well as it also reducing the your cost in the testing of the blood and blood components. So whenever you do a cost at one place, reduce the equipments required for the testing of all those blood components, it will help in that way also. But yes, at the larger level, it is quite challenging in our country as compared to the Western countries where the geographical variation is quite different in that way.
Dr. Gopal, there is another question that they would like to. There is an increase of rate of aluminization in SCD patient compared to thalassemia, even though thalassemics have higher transfusion dependent rate. What is the reason?
The aluminization is quite, you can say, the variation in different kind of the patients. Like the SCB patient also is a transfusion dependent patient, they require the transfusion. Along with the transfusion, there is the many other factors that can also affect the aluminization, like the what is the phenotyping of that particular patient, what kind of the blood they are receiving. Like I mentioned, some in some way the lipid reduction also help in preventing the aluminization. So what the quality of the blood product they are receiving in that way. So as well as the testing methods, what kind of the testing they are performing in that centers, like the immediate spin test or the complete IgG kind of the testing, IgG testing they are doing in that way also. So that other factors also affecting this in aluminization. So in broaden ways, quite variation in that way, you can say.
So another question is, case of massive transfusion, blood is better or component, Dr. Gopal?
Is whole blood concept, yes, you can say initially there was whole blood concept, and nowadays in Western countries, again, the whole blood concept is coming for the massive transfusion patients or trauma or war patients in that way. But the stored whole blood or the fresh whole blood is in that way is what quite key point is there. Because in the stored whole blood, there are components like the coagulation components, coagulation factors, as well as the platelets are not able to much survival as compared to the fresh whole bloods. So in Western countries also, they are again coming up with the fresh blood. I'm sorry, fresh whole bloods only. In fresh whole bloods, all the components is quite, you can say, available, and it help in the improving the patients. But it's not recommended for the whole stored whole blood for this massive transfusion.
मैम ये क्वेश्चन शायद आपके लिए है, तुलिका मैम। सर मैं जानना चाहता हूँ कि बीएमटी के बाद अगर रेमिशन 60% हो और अगर पेशेंट का सीबीसी मेंटेन हो, कोई कॉम्प्लिकेशन नहीं हो, तो क्या पेशेंट को बिल्कुल वेल माना जा सकता है? प्लीज हिंदी में बताएं मैम।
अच्छा, सो ट्रांसप्लांट के बाद कई बार काइमरिज्म हो जाता है, सो दैट मींस कि आपके डोनर एंड रिसिपिएंट सेल्स दोनों हैं, एंड अगर डोनर 60% है, सो थैलेसीमिया में अगर 60% डोनर काइमरिज्म है, तो उससे भी अगर पेशेंट का सीबीसी मेंटेन्ड है, ट्रांसफ्यूजन इंडिपेंडेंट है, तो ट्रांसप्लांट को हम सक्सेस मान सकते हैं। ब्लड कैंसर ये उस ट्रांसप्लांट में वी डोंट वांट एनी डोनर सेल्स, बट थैलेसीमिया सिकल सेल में 60% डोनर काइमरिज्म है और वो स्टेबल है, सो ये सक्सेस माना जा सकता है।
Ma'am, another question in leukemia, what type of blood is transfused to patient? Whole blood or specific component of blood?
So just like Dr. Gopal said, we don't use whole blood now, even in leukemia patients or any other patients who are getting blood transfusion. Packed red blood cells are recommended because the packed red blood cells are concentrated and they can increase the hemoglobin. And leukemia patients may need platelets, and sometimes we even need white blood cell transfusions if there are infections. But the whole blood is not recommended in any patients now.
Thank you, ma'am. And Dr. Vijay, with importance of NAT machine for THAL patients in blood transfusion? Dr. Vijay, can you hear me?
Yes, madam. So, yeah, definitely not for thalassemia patients. It can help for wider population if we can provide more and more safer blood. Okay. So maybe sometime cost is just we look about direct cost. We are not looking about indirect cost. So if patient hepatitis B, cost is again bearing by another program, hepatitis B control program. And if a thalassemic or any patient because of blood transfusion gets some infection, we are losing so much of quality life years, the productive life year of that particular person. So that we don't know how much loss is happening. So I would urge authorities to look into that aspect also. And as a human being, even if one person can get any infection, that should be looked at how can we. So definitely, we should look forward for universal NAT tested blood or any other safer technology which comes in due course. Science is very rapidly evolving. Maybe centralized testing may make it at least not at national level, maybe in zonal level in each state can have 4 or 5 centers or one center who is performing all this high-end testing for all blood which is being collected.
Dr. Vishwas says that blood storage center is a very good option to provide safe blood at remote places. True, agreed, and I totally agreed. If we have, because we started last 4,500 blood storage centers at NHM. I hope they all are working efficiently, and this is very helpful. I mean, even in the states that we have good storage centers and good component storage centers, that is the best idea to have components at the peripheral level, which is, I mean, it should be there that we have good storage centers and good component storage centers, which drugs cosmetic it also agrees to it, but still we have to work on it. So one more question: due to lack of extended phenotype patients of thalassemia patients, many getting blood transferred without phenotype matching. How can we decrease this discrimination based on lack of facility? Is there any mechanism to get it tested all over India? So who can answer this? Chaitanya, can you answer this?
Yes, ma'am.
Yeah.
Actually, most like higher centers like AIMS have these facility. Maybe NIMHANS also has these extended phenotyping matching. In fact, like for example, at AIMS Mangalagiri, we do get patients' requests for doing many immunohematological tests actually. Commonest being whether they're Bombay group or not. We get these referrals from not only government centers, we get from private centers also. Like if you can have a tie-up with a good center nearby, it will definitely help the patient. If you can get these results at the earliest, it will be the patient will be getting much benefit. It's a simple thing, but worth the thing for the patient.
Okay, ma'am, one question for you. Can any tertiary care center get permission to use stem cells for transplant tolerance in case of solid organ transplant? If yes, what is the procedure to get the approval? Ma'am?
In solid organ transplant, we usually do autologous stem cell transplant. And I think the guidelines would be exactly the same as they would be for any other stem cell. Follow the guidelines. The blood bank should be certified, and the apheresis here it would be for the patient because it would be autologous transplant. So again, you have to be very careful because these patients usually will be pediatric patients and they are suffering from a solid cancer. So you need to make sure that all the safety precautions and the guidelines are followed in collection so that it is a safe and smooth procedure. And then these patients would be taken up for bone marrow transplant.
Shobha madam had said replacement of blood for multi-transfused patient will it become a reality. Ma'am, it will definitely become a reality. Yes, we have to work very hard for this. And you have been doing a great job, but others also have to really work for, I mean, getting this. There is no replacement. We all want voluntary, and everybody who comes, so whosoever comes to the blood bank, at least get the blood without replacement. That is the best thing because a person in trauma comes to the blood bank. So it's always better to have a blood without replacement. Dr. J.S. Arora is saying in thalassemia it is recommended to transfuse blood. Ma'am, this is for you. In thalassemia, it is recommended to use fresh blood less than 7 days. How much it matters if RBCs are on 1 week old or 4 week old vis-a-vis oxygen carrying capacity?
So these are guidelines based on experiments, and it is believed that if you use less than 1 week blood, it will benefit the patient and reduce their transfusion frequency. And in many centers, we do try to follow that situation. However, I do counsel my patients that in case the fresh blood is not available, they should not get too panicked, and they should take whatever blood is available. As I said, this was done based on some laboratory studies. We don't really have studies in real world to show that this is an actual fact. But wherever possible, we try to help patients by giving them the freshest blood possible.
A very important question, Dr. Chandranya. The most recent 2024 WHO guidelines say hemoglobin cutoff adults in 15 to 65 years, men is more than 13, normal, and 11 to 12.9 is mild anemia. Perhaps our criteria need revision, though it seems counterproductive in maintaining and increasing our eligible donor pool. Is it?
Always the NBTCs of various nations try to balance the number of donors that they can get as eligible people. That is why they maintain this 12.5, more than 12.5 or equal to 12.5. The hemoglobin cutoff for males and females is taken based on this. If we try to increase the hemoglobin cutoff to more than 13 or more than 14, it will automatically reduce the number of people who will be fit to donate blood. So the entire donor pool will be affected. So usually they don't change so much. This time actually for double red cell collection, they have given a specific criteria of more than 40. This is in specific rare cases actually using Alex, which is a separate component apheresis machine. So these criteria, if we change, it will affect the community at large. So that is why they have taken cutoff of 12.5. I believe the latest NBTC guidelines.
And Gopal, there is a question for you. We all know Dr. J.S. Arora is saying, because he knows well about the blood and thalassemia, we all know leukodepletion and extended red cell, extended phenotype matched transfusion are essential for thalassemia. Government should make it mandatory all over India, at least for thalassemics. Dr. Gopal.
Yes, yes, ma'am. Like I also initially mentioned that it will help in reduction in the adverse transfusion reactions in chronically transfused patients, especially in thalassemia cell disease. So yes, you can say it is the much required to as much as liquid-depleted blood or extended phenotype in transfusion is available for this kind of the patients. But due to quite cost involvement as well as the variability in the type of the blood centers, it is not possible. So government should make mandatory effort for that, since that just minimum for the thalassemia patients and sickle cell anemia patients, they should get a liquid depleted or extended phenotyping. For extended phenotyping, the little bit higher cost is involved because of the anti-seras available are costly as well as the those anti-sera. For that, you can do some kind of the centralized testing for these extended phenotyping, like in particular that district or that area. One center can do the extended phenotyping all that for the all kind of the patients and provide the report from that. So that would also help in improving the transfusion services for that area.
Thank you so much. And Dr. Kumar, because you were talking about Kolar and the Bangalore, many rural patients do not understand the importance of carrying records like phenotyping, etc. How digitalization can help, like adding reports to ABHA or DigiLocker at hospitals who have the facility to extend phenotyping.
So I think, so I think Government of India already has an initiative to work towards to have this our electronic medical record in form of ABHA. So with little knowledge I can understand ABHA ID is going to be universal, where whether I go to Fortis or whether I come to Nimans or AIMS Delhi, if my ABHA ID is placed into the system, clinician should be able to see my medical records wherever it is. So it's already on the card. So that should be there. That's what we have to see centralized. So particularly for blood donation, for transfusion services, also we are looking forward to have this solid, because one donor comes and donates in Bangalore, and another second time he goes to AIMS Delhi. So we don't know what happened in the Nimhans and what is happening. So the eligibility criteria, the deferral criteria, so the plasma product safety, blood safety, that can be, still we get the donors who know that they are seroreactive, but still they enter into the donor pool. So electronic medical records are the only solution which I can see.
Thank you so much. And there is a suggestion from Dr. Vishwas Amin. One should use bulk transfer policy to eliminate replacement transfusion. Corporate hospitals nowadays have outdoor camps permission and still insist donor instead of blood from other blood center. They should be taken up seriously. Okay, it is important. Uh, uh, Dr. J. Sarora says that at some blood bank issue of old blood in spite of having fresh blood, a directive may be issued to issue fresh blood RBCs to thalassemia if it is available. Do you think this directive is important? Anybody can answer this?
Yes, I think this is a good directive. However, we can't make it into an absolute rule because occasionally it may not be possible. But whatever is available, the freshest blood should definitely be first prioritized to thalassemia patients. I think that.
Ma'am, there is another. So I think we can stop it here. And thank you everybody for joining us. It was a very good discussion, and people from across the country have joined us. And you will find the links in YouTube as well. So those who want to learn more, they can again and again listen this and understand what exactly, because this discussion was very healthy. We came to know from very beginning, from the blood donation to blood transfusion to stem cell. So all hierarchies from blood has been taken up. It was a very good decision and very fruitful discussion which held today. And I would like to thank all my speakers who were here, the panelists and moderator, Dr. Tulika said, Dr. I.S. Chaitanya, Dr. Vijay Kumarvat, and Dr. Gopal Patidar. I'm very thankful to all of you because you have joined, given us a time. And NHJ will always be thankful for you for this, because this is the time when we are just consolidating the things what are important for us. And I would also like to thank all the listeners who are here. I can see Ripple also, Dr. J. Sarra, Dr. Shobha, Mrs. Tully, Dr. Yasdeep Dalia, everybody has joined. I mean, across the country, I can see people, and from NTR, Sir Rajenshar has also joined from NTR Trust. I mean, I'm so happy to see everybody together here, and glad to meet you all not in person but virtually. So thank you so much for joining us. And on behalf of NHA, I would like to thank you again and again. And my authorities, I mean senior authorities, my JS and my senior officials will be very happy while listening to these conversations what has been held here. And we will try to consolidate and get it done, as Dr. Vijay said, that there should be no discrepancy. We will try to maintain that. Thank you so much, everybody. Thank you for joining us. And I hope
Thank
it's
you.
not late for you. Thank you so much. Thanks once again.
Thank you.
Thank you, ma'am.
Thank you. Thank you so much. Bye.